how does an infection kill or cause mortality? So, and we have said that we have an infection that can progress to sepsis, and that can progress to septic shock, multi-organ dysfunction, and death. So, and we did speak about, when you talk about multi-organ dysfunction, we did mention that how each organ can present, that's the brain, and we did speak about the heart as well, and also if the liver is involved, how it will present as well, and also if the kidneys are involved, how the patient is gonna be, and also if the bowel is involved, not necessarily the bowel but the mesentery there. And then, oh, why do I keep forgetting the lungs? The lungs. I would encourage you guys to draw when you study, because our minds have got this strong ability of remembering pictures than words. So this is the way I study, and it always works for me. So try to involve a lot of drawings in your study, and that's how you're gonna be able to capture a lot of information. So just to go over it again, so you can have one organ failing or more than one, or all of them. And I did say that when the brain is failing, the patient will can come in with seizures, can come in restless, disorientated, low GCS, confused. They can come in coma, just unresponsive. As far as the heart is concerned, the patient can come in with a tachycardia, a hypotension that might not respond to just fluids, and that patient will need inotropes. The liver, the patient can come in with elevated transaminases like your ALT and your AST, and also increased INR and a decreased glucose. Remember, the liver is very important. It's an important organ when it comes to gluconeogenesis. And the renal, the patient can come in with oliguria, anuria, or acute kidney injury, or full-blown renal failure. And then the bowel, acute mesenteric ischemia. They can present as just an abdominal pain, nausea, vomiting, that kind of a thing. And when it comes to the lungs, a patient that has got low sets, a tachypnea, and abnormal ABGs, and yeah. So these are the. Can you see how important infection is, guys? Can you see how important it is to identify an infection and treat it promptly? Because you don't want to get there. Yeah. So now, how on earth does a person move from infection to multi-organ dysfunction? Like I said, the problem is not only the bacteria or the pathogen, it's this systemic response that we get, and that systemic response, it's mainly those cytokines, and also bacterial toxins. So they're the ones that cause. So the main issue is all this causes hypoperfusion. Hypoperfusion of those vital organs. And when they are hypoperfused, you get ischemia, and you get, remember, once you get ischemia, you get necrosis. Now you've got parts of your brain that are necrosed, you've got part of your kidneys that are necrosed, and that kind of a thing. So you get necrosis. So some organs are very sensitive to hypoperfusion and ischemia. Let me tell you something about what they call an MAP, mean arterial pressure. When you've got a patient who's got hypotension, you know, people who deal with critical medicine, they will tell you that the blood pressure is not the biggest thing that they look at, but they look at the mean arterial pressure, which they want it to be above 60. Some say above 65. What is a mean arterial pressure? Yes, we know how to calculate it, that's fine, but a mean arterial pressure is the pressure at which organs are perfused. So organs are not perfused by a blood pressure of 120/80. They are perfused by a mean arterial pressure. So once you get a drop in your mean arterial pressure, it means now your lungs are your organs are hypoperfused because of that drop in MAP. You can have a drop in your blood pressure and have a good MAP. That patient is fine, because what you are concerned about is perfusion to the vital organs. So as long as you are maintaining that, your patient should be fine. What leads us to this is the hypoperfusion. That's the main. Yes, there are other mechanisms as well, but the most important one is hypoperfusion, which you get with sepsis. Once you get sepsis and then get into septic shock, hypoperfusion, you get a drop in blood pressure and a drop in your MAP, then you are gonna get to hypoperfusion of your vital organs, and that's gonna make them to go into dysfunction. Okay, so guys, I hope you appreciate the fact that it's not possible for a bacteria or whatever pathogen to cause all of this. I mean, if the infection is in the knee, now for a bacteria to cause all of these, if it was the bacteria that was causing all of these, for it to actually cause all of this, it would mean that from that septic knee, it must go to the brain, go to the heart, go to the liver, go to the lungs, go to the heart, and it's not possible. So it's because of those toxins, it's because of the inflammatory response that you get, the cytokine release and all of that. So those inflammatory mediators, your pro-inflammatory mediators, or your inflammatory mediators, all those things, they are the culprits. There's something that they call SARS, even though some people do not recognize it anymore, but this is where it is. SARS is a systemic inflammatory response syndrome, and it looks at things like temperature. A temperature can either be a fever or a hypothermia. I think the figures that they use for hypothermia, it must be less than, is it 35? I can't remember. But for a fever, for a hypothermia, I can't remember this number. But please guys go and look it up. For fever for them, according to that, says it must be more than 38 degrees. And then they look at the respiratory rate, which must be more than 20. They look at a white cell count, which a patient can either be less than 5 or more than 12. That's leukocytosis, that's leukopenia. And then they also look at the pulse, right? And then they use 90, which I have a problem with. I think they use 90 there for the pulse, and there are 4 things there in that thing. What am I forgetting? It's there. I can't remember what I'm forgetting. Is it the blood pressure? I'm not sure. But guys, please go and look this up. Systemic inflammatory response syndrome. Once you've got a patient who has got an infection, doesn't matter where the infection is, once they've got these one, I think they say 2 or more of these, that patient has got systemic inflammatory response syndrome already. Don't wait for them to get into septic shock before you can act. So even though many people do not talk about SARS anymore, but there are people who are still using it, so it's important to know about it. So if you look at this says systemic inflammatory response. It's systemic. It's not localized. It's systemic. You cannot be talking about SARS when you have just an infection. You talk about SARS when it's systemic. That's what I've been emphasizing, that sepsis and an infection cannot be used interchangeably. They mean 2 different things, because sepsis is a progression of the infection. So if you can look at this already, now you've got different organs involved. The fact that you've got a high temperature, it shows that it's systemic now. The fact that you've got a high RR, it means now the lungs are involved, and a tachycardia, the heart is involved, and all of that. So I hope guys from today you are going to appreciate that infection is not just infection. Now, what determines what are the determinants of the severity of the infection? I'm gonna mention a few, but not all of them. Extreme age, the very young and the very old. Very old is usually more than 65. That's how they define it. And the people with immunosuppression. So basically, who is likely to die of an infection? The extreme age, those who are immunosuppressed. And when we talk about immunosuppression, it's not only people who have got who are HIV positive. People who are on steroids are at risk. People who have done a splenectomy. Remember what the spleen does? The complement, especially bacteria that have got a capsule, right? Yeah. Some people who are on chemo drugs, people who have got some kind of malignancy. Malignancy on its own is immunosuppressive, and even chemo drugs are immunosuppressive. And so remember that immunosuppression is not always equals to HIV. And also people have got people who are of low socio-economic status, and people who have got some malnutrition, or people who have got what other word can I use for this? I can't think of another word now. And the location of the infection is very important. A patient who's got an infection in the neck is more likely to complicate than a patient who's got an infection in the leg. And also infection in the neck, in the face, in the scalp. Those are serious infections, and I wouldn't want to discharge a patient, even though it's just an infection. I wouldn't want to discharge. Remember, if a patient has got an infection in the scalp, that infection is very close to the brain. If a patient has got an infection in the neck, that infection is very close to the brain and to the heart. Yeah. So the location of the infection is important, and we always talk about other chronic illnesses, comorbidities. So there are other things that determines the severity of the infection in patients. So it ranges and all of that. And also the aggression, how aggressive your immune system responds to infection is also a determining factor of how sick are you gonna be. It's just like someone who's got an allergy. People who've got an allergy, their immune system is very aggressive and is misinterpreting things that are not pathological as pathological. And someone who doesn't have an allergy, it means that the immune system does not listen. For instance, if you've got an allergy to a peanut, the person who's got an allergy to a peanut, the body sees the protein in the peanut as a pathogen. That's why it initiates a response to it. And then someone who eats a peanut who doesn't have an allergy is because the immune system can see that this is, as much as this is foreign, because the peanut is foreign, but it's not harmful. So that person's immune system does not trigger any defense response against that. So yeah, the other things as well, guys. I'm not sure if I'm leaving anything out. Yeah. So basically, when you see a patient in OPD who has got any kind of an infection, yours is to look at the location. I mean, someone who's got an infection who lives in the street is more likely to die from that infection just because they live in the streets. They don't eat properly. They don't have they don't bath properly because they have access to water, and they don't and they're outside in the cold. So those factors, they do play a role. That's why those patients, you just want to admit them just because they are from the street, they've got an infection. Unlike someone who's living in a good house, who's got food, they might cope better with the infection, even though they've got the same infection. So you look at the factors around that patient. And so yours is to look at the location, the whole circumstances of the patient, the location in the sense that where is the infection, look at the vital signs, what are they saying, look at your bloods and all of that. Yes, your investigations are gonna include your. It's always nice when you have located the infection, or yeah. So your FBC with your differentials, your UNE, and approach to these patients always depends on where are you seeing them. Are you seeing them in the emergency department or in OPD? Because if they're in the emergency department, they might come in already with septic shock, and you might need to research first. UNE, LFTs, CRP. CRP is very good. It's also good to monitor the progress of the infection as well. So I like it as a baseline as well. So these would be your basic blood. Some people wanna add would like to add ASR as well. So what is important is that those are like your basics. Now, depending on the history and examination, your other tests, whether you do a chest X-ray, whether you do whatever, whether you do an X-ray of a certain limb, if you think there's a osteomyelitis. So the other test will be guided by the history and the examination that you have done. What is it giving you? What is it hinting you towards, and all of that. So guys, this video is already 22 minutes already. I think we have covered a lot of things. So now I think what I'm gonna do in terms of infections now, the discussions that we're gonna have is talking about specific infections. Yeah, maybe UTI, talk about pneumonia, talk about meningitis, talk about cellulitis, the common things. Guys, thank you for supporting.